Hello everyone, welcome to our webinar. Today we're presenting on tobacco cessation and opportunities for Maricopa County. My name is Nicole Mueller and I'm with the Behavioral Health and Wellness Program at the University of Colorado School of Medicine. I'm going to be presenting today with Dr. Chad Morris, our director. So today's objectives are going to be expand on the evidence base that exists for tobacco cessation and justice-involved populations. And this is something we started to explore at the project kickoff meeting. We're also going to review the results from the Maricopa County Staff Knowledge and Behavior Survey. So that was the second survey that we did. We didn't discuss these results at the kickoff meeting. Instead, we waited until we were able to get some more participants. And so we'll finally go over those results today. We're going to discuss opportunities that are identified during site visits and additionally with those surveys. We'll provide an overview of relevant tobacco programming that we offer, and then additionally review some next steps for the project overall. So first we want to jump into a little bit of background about state and federal tobacco policy. So first, in 2004, the Federal Bureau of Prisons first made all facilities that were under its control 100% smoke-free. And after that time, a lot of state and local facilities followed suit. Including Maricopa County, which has its own tobacco-free policy that applies to correctional facilities at the county level. But what's happened is that even though these policies that set a ban on indoor smoking and in some cases on outdoor smoking and tobacco use as well, there's been an absence of cessation support for justice-involved individuals. And part of this might be due to the fact that tobacco use in criminal justice settings has been historically condoned. So corrections staff actually commonly possess negative attitudes towards cessation services. Just to show how far this goes, a recent literature review found that although there's been an increase in tobacco-free policies in jails across the country, the majority of those institutions don't actually offer cessation support to inmates. So 5 out of 23 studies that were examined in that literature review who had tobacco-free policies offered cessation supports. So you can see that the vast majority don't actually offer these services. So accordingly, Maricopa's effort with the Justice-Involved Tobacco Cessation Project is actually incredibly innovative and a really exciting opportunity to be a model for a lot of other institutions and systems in the country. Now, quitting tobacco is really difficult, and that's something that we know. And these quotes are actually things that were said on the Maricopa County Public Health Survey of adult probationers, where they were looking at tobacco use and attitudes around tobacco use with probationers at a few select sites across the county. And what we know is that the majority of individuals who stop smoking because of a tobacco-free ban or policy or ban in prisons begin smoking again upon their release. So one survey of community corrections programs found that 97% of individuals who left those smoke-free or tobacco-free facilities started smoking again within 6 months of their release. So what we know is that forced abstinence in correctional institutions isn't enough, and that stopping smoking for a period of time, even if you no longer experience withdrawal symptoms, is not the same as actually quitting tobacco. However, despite the fact that it's very difficult for justice-involved individuals to quit for a variety of reasons, that doesn't mean that the desire to quit doesn't exist. And surveys have actually found that for those who are in community correction systems, over 50% of those individuals who are smokers or tobacco users indicate interest in receiving cessation help if it were available to them. And then furthermore, of those individuals, 60% also said that they'd be interested in some sort of pharmacotherapy to help them to quit. So that interest is there. It's just finding ways to deliver the services where they're needed. And while the evidence base around tobacco cessation in community corrections and just in justice-involved populations is rather limited, there are some effective interventions that have been identified. So some of those interventions include motivational interviewing or cognitive behavioral therapy, pre-release planning and addressing intent. They include group therapy and then pharmacotherapy. So just for example, a 2013 WISE clinical trial that was implemented where prisoners in a tobacco-free prison received motivational interviewing sessions and cognitive behavioral therapy sessions, compared to a control group of prisoners who only viewed a variety of videos on health-related topics, was studied, and then researchers found that at 3 weeks, abstinence rates were 24.5% and 70.2% respectively. So that's a pretty significant increase. So you can really see that cognitive behavioral therapy and motivational interviewing make a difference in that context. And that rate is actually relatively comparable to the general population as well. And then when you're thinking about pre-release planning for tobacco cessation, without that planning, many individuals do tend to relapse. But one important factor to stress is making sure to assess an individual's intent to maintain change once released. So that in some respects ties into motivational interviewing as well, creating that motivation and the intent to quit before they're actually released from correctional facilities. And post-release intentions to smoke were an extremely strong indicator for remaining tobacco-free in a recent study. And an individual's intent or motivation to remain tobacco-free could be impacted by interventions received while incarcerated, so such as tobacco cessation or pre-release planning. And then finally, with the group therapy and pharmacotherapy, we're going to discuss those extensively as we move forward in this presentation. So now we want to take just a couple of minutes to talk about some of the data that we found with the Maricopa County Staff Knowledge and Behavior Survey. So this was a survey that was instituted between July and August at different pilot sites that were identified across the county, and we asked that staff complete a number of questions that pertained to their knowledge around evidence-based tobacco cessation services, and then additionally their attitudes towards tobacco and tobacco cessation. So for the whole study, we had about 46 participants, which, considering the size of the pilot sites, we think is a fairly good response rate. And we think that the sample size will be fairly representative when we're talking about the data. But we do want to note that the majority of the staff members were from the drug court, which I think is the largest organization that is participating as a pilot site. And then all respondents reported that they had direct contact with justice-involved individuals. And the majority of respondents didn't identify as healthcare providers, but the majority of respondents did provide substance use or mental health services. So what we did find is that about 40% of respondents are ever tobacco users, which is to say that those individuals indicated that they had regularly used tobacco products at some point in their lifetime. That doesn't necessarily mean that they're current smokers. And we did ask about current smoking status, but because of a relatively low response rate on that question in particular, we can't necessarily say that we have an exact prevalence rate for current smoking among pilot site staff. But when you look at the breakdown of what products are commonly used among staff at the pilot sites, you can see that cigarettes are very widely used, followed by smokeless tobacco and then e-cigarettes and vaping. And this will add up to more than 100% just because people were able to indicate that they use more than one tobacco product. And then even though there was a low response rate, it was about 33% of individuals who reported being ever smokers who reported that they have current tobacco use. So this is important to know and to consider because research has found that providers who are themselves smokers are actually less likely to ask their patients about smoking status and to offer their patients assistance with regard to smoking cessation. But those providers who themselves have quit smoking are far more likely to ask about smoking status and then to later offer their patients assistance with tobacco cessation. So accordingly, for the implementation of a successful tobacco-free policy or intervention in correctional facilities, it's recommended that you don't just address tobacco use by justice-involved individuals, but additionally employees and other staff members at the facilities. So the Staff Knowledge and Behavior Survey was divided up into two large sections. So one primarily assessed staff knowledge of tobacco cessation strategies. So it included a wide variety of evidence-based strategies, including asking about tobacco use, referrals to the ASH line, the 5A's model, all of the things you see listed here. And what staff were asked to do is to rate their general knowledge of these different strategies. Oops. So overall, we found that staff members report limited knowledge of evidence-based tobacco cessation strategies. And that's not surprising, and that's not bad. So if you see here, this is just a graph that shows the aggregate data and not necessarily the specific breakdown. But you can see when individuals had little knowledge, they were rated with a lower number. And then when they had higher knowledge, they received a higher number on the scale. So from 1 to 10, there's no tobacco cessation method that got over maybe a 3.5. So there's a lot of room to grow in order to improve staff knowledge around tobacco cessation services. And this is very common in most organizations that work with justice-involved individuals and as well as individuals with behavioral health conditions. But when you look at the breakdown further of these different categories, and I realize it's hard to read here, but we're just going for the overall picture. You can see that the individuals who reported having no knowledge of these services far outweighed those who reported having extensive knowledge. So if you look at the graph, the people who reported having no knowledge or little knowledge can be seen in the green and the blue categories. So for all of the different interventions like motivational interviewing, nicotine replacement therapy use, providing messaging around tobacco-free policies is one of the categories, all have pretty high rates of no knowledge that were reported by staff. And again, that's to be expected. But there are some areas where there was more extensive knowledge that was reported, and that's the kind of pink-orange color that you see at the end on the opposite spectrum. And so those highest levels of staff knowledge were found in asking about tobacco use, in advising about not to use tobacco, and then using cognitive behavioral therapy or motivational interviewing. And those areas where we really found the lowest levels of knowledge were the 5 A's model, which we'll get into a little bit as we move forward, the 2 A's and an R model, which relates to the 5 A's model as a simple mode of intervention, and then additionally documenting tobacco use, and this specifically asked about EHRs. And then the second component of the staff knowledge and behavior survey asked about staff attitudes towards tobacco. So really it was looking into how they felt about integrating tobacco cessation services into their workflows, and additionally what they thought about tobacco cessation services just generally. So some of those categories included whether or not it was feasible for respondents to provide cessation services given their current role, or that staff had the resources at their agency that they needed in order to provide those tobacco cessation interventions, or the time. And then it also asked about their interest in promoting tobacco-free policy and that type of thing. So in total, what we found here is that overall, despite relatively limited knowledge of evidence-based tobacco cessation services, staff actually highly valued tobacco cessation overall. And that was a relatively surprising finding. That's not necessarily always the case in corrections. So a majority, and that was almost 60%, agreed or strongly agreed that it was important for the justice-involved individuals that they serve to receive tobacco prevention and cessation services. And then additionally, over 3/4, so almost 80%, agreed or strongly agreed that tobacco cessation was possible for the justice-involved individuals that they serve. And then that statistic in particular is important given that research shows that the primary barrier that providers face or perceive in providing tobacco cessation treatment for the patients is the belief that their patients can't stop smoking, or alternatively that they're not interested in smoking. And that ties back to the idea of smoking as being a choice rather than an addiction. However, staff did show some hesitation in particular categories. And again, that's to be expected. So for example, while 53% of staff members agreed or strongly agreed that given their existing role and responsibilities, that it was feasible to also provide brief tobacco prevention and cessation services, 34% disagreed or strongly disagreed that their staff had sufficient time to provide those services. But interventions don't necessarily have to be long or intensive to be effective, and that's something we'll talk about a little bit further too. So you can see some of the breakdown in the data here, and you can see the color coding is relatively similar. So on the one spectrum, you can look at the green, and that's those individuals who strongly disagreed with particular statements. whereas the kind of pink-orange color and the blue represent people who agree or strongly agree. So it's much higher levels than staff knowledge. The highest levels were staff who agreed that there's no safe level of secondhand smoke. Additionally, staff who supported a tobacco-free policy and who believed that smoking cessation is possible for the individuals they serve. And the lowest level of agreement was that staff at their agency have time to provide those cessation services.
Thanks, Nicole, for going over that. And this is Chad Morris. And so for those of you who I haven't had the pleasure to meet yet, I direct the Behavioral Health and Wellness Program at the University of Colorado. And we wanted to now shift gears a little bit based on both some of the evidence base that Nicole shared, but then also the survey findings. And once again, set the stage for the tobacco cessation pilot that we're proposing and move into some of what we hope to offer those pilot sites and what the next steps would be in doing so. And so just, and some of you have seen some of these slides before, but I wanted to put up about 3 slides that really show both the theoretical underpinnings, the evidence-based underpinnings, as well as what we would say the practice-based underpinnings of what we were looking at, combining these different underpinnings to see what might be the most appropriate place to intervene in the Maricopa criminal justice system. And so the first one, and this is really aligned with our philosophy at the Behavioral Health and Wellness Program, is that we are a whole health program. And so you're seeing that we operate across 8 dimensions of wellness. You see them all listed up here. And the notion that in the approach that we take is that in doing our work around tobacco cessation, tobacco control generally, that it's very, works very effectively to actually integrate those initiatives into a whole health platform and approach it from that respect, even though we're, in this case, of course, we're focusing much more on the tobacco side. But we find that if we're integrating some of these other elements into that tobacco work, that we're much more successful. And so the other underpinning that we looked at very closely, which is very familiar to most individuals that work in the criminal justice system, is the sequential intercept model. So really what we were looking at is, well, if we have this philosophy around whole health programming, really where are we going to get the biggest bang for our buck? So where really should we concentrate our efforts at what intercept point should it be? So, on the far left-hand side, or should we really be focusing on law enforcement, or should we be moving into court hearings, or the jails and courts, our reentry programming, our community corrections? And we very quickly found that really what seemed to make the most sense from both the evidence base, but also organizational readiness for change and just buy-in and really practical issues, is looking at intercepts 4 and 5. So looking at what we can do with reentry programming as well as community corrections. And then the other model that we were operating from is the patient-centered medical home neighborhood, or the patient-centered medical neighborhood. And so this is different than the patient-centered medical home in that the patient-centered medical home model would say that really we have to always concentrate or operate out of the hub of public or primary care setting. And so this is really saying, we can actually operate from any point of service, and any of these can become the hub of care. And what we're really looking at is, where are folks accessing care? Where are they showing up? What are the hubs of care that the criminal justice system is naturally interacting with? And so we're putting all 3 of these pieces together, and we had the opportunity to then come out and visit a lot of sites, potential pilot sites, in July. Was it July, Nicole, that we were out?
August.
In August, when we came out and we were able to visit a lot of you to see, given all of what we know regarding the evidence-based and practice-based medicine, we're in healthcare where again should we really concentrate these efforts? And in doing that, our hope was that we would be able to reach into jails and prisons, and then really look at establishing those relationships, starting those services in jails, for instance, in the Maricopa jails and in the prison system, and then really walking folks into those community hubs of care. And so establishing a continuity of care model that would be sustainable and feasible over time. And one of the things we're going to talk about that's noted in this slide is tobacco-free advanced techniques for providers and peers. And we're going to delve into that a little bit about where we're hoping to head from here as far as some of the training offerings and so forth. And so what was really amazing when we came out, and I think everyone agreed, is that we came out thinking that we would meet with a variety of pilot sites, and maybe one or two sites might be, ready or have the buy-in or really be interested in this topic and understand the value of it. But really what ended up happening is that all the pilot sites that we visited were they were ready to go. And their value base was there, and this was reflected in the survey findings that Nicole put up as well. So it wasn't just the leadership necessarily, it was we're really hearing this from the staff as well. And so all of these sites that we visited, we feel are ready to actually become pilot sites as we move forward. So that's the Maricopa County Drug Court, and under that, the Western Regional Center in the Black Canyon Building, the Veteran Pods Towers Jail, Mosaic, both Estrella and Durango, and then Hope Lives. And I'm going to encourage Nicole, if you want to jump in at any point to say anything about these, you can do that as well. So that it was incredibly encouraging, and again, somewhat surprising to find that there's so much interest in this and knowledge that, in terms of how much tobacco affects the lives of these individuals, and that we can do something about it and do it fairly quickly. And so based on that, I wanted to just put up our one-year timeline. And this has actually shifted quite a bit, just because, again, we weren't necessarily expecting that all of you were so willing and ready to go. And so we were thinking that we might actually, it might take until next July to really identify some of the pilot sites that we would initially work with, and then kind of roll into other pilot sites, et cetera. What you're seeing here is the updated one-year timeline for this project. And so, as we mentioned, we came out in July, August, and did the kickoff meeting and the pilot site visits. And at the same time we were doing that, we were starting to gather this evidence base and review that evidence base, and particularly in light of the Maricopa information in the background and what we knew about your systems. And so that is in part what Nicole is starting to share with you in this webinar. But really where we're at after this survey administration, we have all these facts. What we're moving into is not only the webinar today, so you'll see that in October 2017 listed here, where we're starting to review some of this survey data. And we're going to also review some of our offerings and the trainings we hope to accomplish, not just this year, but also in the coming years potentially as well. But what's coming down the pike as well very quickly is that we're going to put out some reports. And so those are both going to be reports on the evidence-based practices, but then also reports on the survey assessment data. And we're going to talk a little bit more about what those are going to look like. And so what we're hoping to do is in February, March timeframe is really come out and do some of that first staff training. So again, this is something that we thought wasn't going to happen until year 2, but you all ready to roll with this. And so we were more than willing to revise this timeline and get some of that training going, and so that we don't have to stall any of this excitement out in regard to this project. And so at the same time, we'll be looking at a draft strategic plan. So that's a 5-year plan for how Maricopa is going to move forward with this, and we'll revise that strategic plan by in around the April timeframe, and have that final plan, strategic plan that we can then present to you, and then have a kickoff forum and get the tobacco-free groups, for instance, going. And so this is what the first year timeline is looking like, and we're really excited about how far we are in regard to this. So some of the opportunities for Maricopa County right now, we want to get into this and where we hope to go in the coming months here. And so initially, just again, based on the survey findings that Nicole was giving you the general, really the aggregate findings, if you will, on this, is that it would make a lot of sense to spend some time on the 5 A's and what we call the 2 A's and R. And I have a slide coming up that talks a little more about that. And then also, it seems like there's a real opportunity to offer cessation pharmacotherapy, probably in the form of nicotine replacement therapy. And Nicole's going to talk a little bit about that and give you a little teaser about a webinar that we'd like to do coming up. And then we would love to get into, again, more in that kind of March timeframe, actually coming out and training on our tobacco-free groups that we're going to talk about as well. We also feel like it's important to really start integrating the ASH line and the quit line services. And so talking about how to do that and possibilities for tailoring that work. And ASH line's been very, very much on board and a part of this from the get-go. And then talk to each one of the pilot sites individually about how all this is going to work. And so really integrating tobacco cessation, tobacco control into existing workflows, but knowing that this is going to have to be individualized based on with each pilot site that's going to be involved. So some opportunities that we have coming up, and we can stage these and phase these in. Of course, we can't do everything at the same time, but really looking at motivational interviewing enhancements. We weren't surprised that a lot of staff have some awareness or have some education training in motivational interviewing. It's very prevalent in criminal justice. But there is a lot of room for doing some enhancements around whole health and tobacco specifically. And so that might be a real area for more education. Also, tobacco-free policy enforcement and expansion. We know Maricopa has tobacco-free policies, but we also know, in talking to all of you and you sharing with us, that enforcement's often an issue, for instance. So looking at how we can help you in that regard, in both on enforcement and expanding policy, for instance, because we know that how much that policy will reinforce and help the effectiveness of any kind of counseling or other treatment that's being offered. And then down the pike a bit, so probably not this year, talking about tobacco treatment specialist training, some well-body programming training, and also how you might be able to integrate peer programming. So peers that have a lived experience with criminal justice, how you can start to integrate them into your workflows as well. So we, again, just from a very basic stance, if you go to the guidelines for treating tobacco use and dependence, we know that counseling and medication are effective when used by themselves, but it's really the combination that works the best. So this is why we like to treat tobacco very much like any other kind of chronic illness, whether it's asthma or diabetes or so forth, because we know that and even some most psychiatric disorders, whether it's bipolar disorder or schizophrenia or depression, that the most effective thing is going to be to offer behavioral interventions along with medication interventions. And so that's what a lot of our training really focuses on, is the fact that the tobacco dependence, like other chronic illnesses, has two parts. It's a two-part problem. So we really need to focus on that physical side and treat the physical addiction through medications for cessation, so that individuals can benefit by behavioral strategies. If they're going through withdrawal or they're having cravings, they have a really hard time benefiting by group strategies or individual strategies. And so this is why it's really important to address both the addiction as well as the habit as we move forward. And one of the best ways to do this is what we call the 5 A's. So it's asking about tobacco use, advising not to use, assessing dependence level, assisting folks with where they need to go to get treatment, and then arranging follow-up. And so while the knowledge base seemed to be low in some of these areas for the staff that respond to the survey, part of that's probably terminology, that staff is using different terminology for some of this, because I believe that you're probably doing most of this in regard to other substance abuse treatment that you're doing. And so it's really, again, just trying to figure out and make sure we're speaking the same language and integrating these activities into tobacco treatment as well. And we have a bunch of, and we've shared this with some of our previous webinars and when we're on site, but we just have a lot of resources for you all as we move forward. And that's both the evidence base around tobacco generally, our tobacco-free policy toolkit. At this point, we've taken hundreds, probably 400 or 500 agencies tobacco-free. So we know the stages to do that, and we know how to concentrate on issues such as enforcement. And then something that's going to be really important moving forward in the shorter term is working with each of the pilot sites individually to look at your workflow. And we've done that both in criminal justice world, but a lot in the healthcare world generally. And so we have some nice tools to help map that out and really make this hopefully a very low burden initiative, because that's always the biggest concern, and that's what the survey showed too, is that are you really going to have the staffing and the resources to pull this off? And we would say definitely you do, and we want to help you make it as low burden and integrated as possible. And along with the basic guidance for tobacco in treating tobacco, then we have our supplements for justice-involved populations. And so all these are, again, available to you to download and disseminate and use as you will. We also have a tobacco-free or a Dimensions toolkit for well bodies, so for other issues that the justice-involved population is facing as well. So all these can be found on our website, and we're actually going to talk about a website specifically for this project where all of these materials will also be available to you. And so I'm going to hand it over to Nicole again to give you a little teaser of one issue that we feel like we need to pay a little more attention to.
Yeah, so we're going to go into this in more detail eventually. We'll offer another webinar presentation on pharmacotherapy, but we did want to give you a brief overview of pharmacotherapy today, and because it is so important and can help individuals to quit, and additionally give a little bit of a background on NRT use in justice-involved populations. So the first question might be, why use a medication for quitting? So cessation medications are designed to help alleviate nicotine withdrawal. So really they mimic the effects of nicotine, or they block the effects of nicotine. So as Chad had mentioned before when he's talking about the two sides of tobacco addiction, the physical and the behavioral, what the medication does is it makes people comfortable while they're quitting by reducing withdrawal symptoms so that they can focus on that behavior change, which is so important. And without that assistance, it can be really difficult for individuals to be able to concentrate on making that change and the adjustments in their life that they need in order to make the adjustment to becoming a non-smoker. So using cessation medications really improves the chances of a successful quit attempt. And that's been found time and time again, and is also true in the justice-involved population as well as the general population. So if you look at tobacco cessation treatment strategies, you can see just how effective medication alone and then medication plus counseling can be. So if you look at the first row where you have the unaided quit attempt, you have the legend of the cold turkey quit, which works for some individuals, but not for everyone. And as you can see, the abstinence rate for unaided quit attempts is 4 to 7%. But as you move down the line there, you can see with help like the quit line or with individual counseling, the abstinence rates begin to grow. And then with medication alone, abstinence rates can be up to 22%, and medication with counseling, which is really the gold standard, is 25 to 30%. So you can see what a difference combination treatment can really make. And one thing we always want to emphasize is that NRT is safe. And there's often concern with different populations about the use of NRT in those populations, so particularly with individuals with behavioral health conditions, but there are no interactions with most psychiatric medications. And in fact, there's actually, there can be dangerous levels of medication and things associated with using psychiatric medications when you're actually using tobacco. So that's something to consider as well. But additionally, NRT is safe in the presence of cardiovascular disease. It's effective in patients with COPD, chronic obstructive pulmonary disease. It's safe while individuals are still smoking, and it's actually recommended that individuals start using NRT before their quit attempt. And there are some general precautions. So NRT shouldn't be used within 2 weeks of a heart attack, or if an individual has a serious arrhythmia or worsening angina. But for the most part, NRT is safe in almost all populations across the board. And there's a variety of tobacco cessation medications that are available. So there's been only a small number that have been actually approved by the FDA for tobacco cessation, and those include nicotine gum and the lozenge, which are often used to supplement the patch, which is included, or the nicotine nasal spray. There's the inhaler, or bupropion or varenicline, which don't actually contain nicotine, but can help individuals to quit nonetheless. So depending on the individual, one medication may work better than another. So really it's up to them to drive what's best for them. But when we're thinking about a justice-involved population, what can be provided, any medication generally is an improvement and is useful. So then when you start thinking about the use of NRT in justice-involved populations, it's very similar to the general population, where incarcerated adults or prison staff and studies have been found to really benefit from the use of cessation medications. So a 2017 systematic review of different studies that involved NRT and other cessation interventions for the justice-involved population actually found that multi-component programs, so those that include both counseling and the use of some sort of pharmacotherapy or NRT, are the most effective. So again, just like the general population. And 10 of those studies that were included in that review demonstrated that cessation can have a significant, medication can have a significant impact. And the pharmacological treatment is key to some of those interventions. So when you're thinking about the justice-involved population, you also have to consider, though, that medication adherence is key. So it might be difficult for individuals who are justice-involved to make sure that they're obtaining medication. There's been a number of studies that show that individuals who are either low SES or who are justice-involved have a very difficult time in accessing this type of cessation medication. It's not necessarily inexpensive. But even in studies where this medication has been provided for a reduced price, these individuals have had a difficult time purchasing or haven't chosen to purchase these medications. There was one study out of Australia that showed even when government subsidized, only 2 out of almost 200 study participants accessed NRT throughout the study. So making sure that individuals are adhering to medication has a significant impact on whether or not they're actually able to quit. And now studies in justice-involved populations are looking at how they can increase medication adherence within those populations. So there was one study that had found that even when NRT was provided in an intervention for free, that 50% of those who were provided with cessation medications didn't actually follow through on taking those medications consistently. So the same research team just came out this year with another study that looked at how what they called in vivo sampling, so where they gave small samples of different types of NRT and walked through during brief interventions and counseling how to use those different types of nicotine replacement therapy, actually improved medication adherence within justice-involved populations. So then another consideration when you're thinking about the justice-involved population is the timing of NRT administration. So NRT helps to combat withdrawal symptoms. But if an individual isn't necessarily experiencing withdrawal, say they've been incarcerated for a long period of time, normally withdrawal symptoms disappear after 2 weeks to a month, then the NRT may not be as effective. But when you're thinking about helping people to plan for their release and that sort of thing, that might be another time to start contemplating using NRT or providing NRT and counseling around NRT. Additionally, we wanted to just reiterate that prisoners and justice-involved individuals are interested in pharmacotherapy. So there's the study we mentioned earlier where 60% of those in community corrections had indicated an interest in using pharmacotherapy to help them quit. But then at the same time, they're unlikely to use NRT. And then there's always concern with the justice of all population about the possibility for abuse, or that NRT or similar medications could become contraband. And that has been found in different studies to happen. And unfortunately, there's not necessarily a best practice guide or anything that exists currently. Some studies have looked at the way that they actually administer NRT and providing it in small groups and really monitoring it at a particular time in the day. But that's just something that we'll have to work through and plan around.
Thanks, Nicole.
Yep.
So I'm based on that too. So again, this is the second part of the two-part intervention. If we get into behavioral interventions and counseling and support, I think every site we visited, if I'm remembering right, was running some kind of group, and so you're very familiar with group strategies. And they're really essential in helping individuals that are smoking prepare and plan for their quit attempt and change behaviors related to tobacco use. So you can do this individually, but again, from a resource perspective, it's very helpful to do it in a group type of intervention. And so we have our Dimensions Advanced Techniques program. So it's our Dimensions Tobacco-Free Advanced Techniques program. And this, we really started this around 2006 through 2008. We've trained thousands of providers in this. This is up and going in 21 states, probably more than that at this point. And it's also been used extensively in certain criminal justice systems. So Arkansas is one where this is mandated programming through all community corrections throughout the state. And it's a program that focuses on motivational engagement strategies. We have a manualized group process, and we also focus on community referrals and educational activities. And so it's embedded fully in that 5 A's model that we talked about a little earlier. And what we do, this is a train the trainer model, and we feel like that's extremely important. And so as we train folks at pilot sites, they're given the materials, if they go through the training, to then train others at their site and keep that pipeline of facilitators available. And so folks that go through this training, staff that go through this training, have all the electronic versions of the training manuals, the training slide sets, etc., and really looking at this manualized 6-week curriculum that you're seeing here. And we're not going to get into a lot of the specifics, but a lot of these you'll see have overlap. These topics have a lot of overlap with a lot of the other behavioral group counseling that you're probably doing. So it's not going to be anything that's foreign to you, except for some of the specifics around tobacco itself. Our group structure, we did several things, and we did these very thoughtfully, in that most of our groups are really open group structures. So as soon as someone's has an interest in quitting, wants to quit, or just wants to look into it further, they can join at any point in the group structure. So they don't have to wait for session 1 to join. And so, in a lot of cases, participants can attend as many sessions as they want, and sessions just cycle over 6-week periods. And we found this to be very consistent with a lot of the interventions that you're using. And so they seem to fit very naturally into the group scheduling that you're using, as well as just the philosophy of the groups as well. And it's really, it's up to the individual sites on who is going to be involved in the groups. But, just from a general sense, they're open to anyone interested in learning about the tobacco cessation. So they don't have to come in saying, I want to quit in week 1 or week 2, et cetera. And then it's really going to be up to the sites if this might be mandated for certain individuals or not. And that would be part of the workflow assessment we help you with. Some of the other trainings that we're able to offer either this year or in coming years are, again, the motivational interviewing. So we have our Motivational Interviewing Institute here, and we also travel and do this training, both at level 1 and level 2, again, talking about engaging, focusing, evoking, and planning with folks around behavioral change. And what is different, again, from maybe some of the motivational interviewing that individuals have received, staff have received, is that this is going to be specifically tailored not only to tobacco cessation, but really around wellness generally. And so it's really going to build off of any other knowledge base that you already have. We also would like to, probably in future years, talk about offering tobacco treatment specialist training. So really having at least core champions at the different sites go through this process and become those true experts when it comes to tobacco treatment. And so we're one of, I believe it's 16 accredited sites, is that right? Mm-hmm. Nationally. And so folks often travel to us to do this training, but we might be talking to Maricopa about actually just bringing the program out to Arizona to allow all of your sites to get trained up in this. And then looking also in the future at the well body work that we do. So that's really focused on healthy eating, physical activity, stress reduction, and sleep. Those things all interact very heavily in affecting health in general, and they interact with tobacco a lot. And so this is just the companion to our tobacco group, where we do the same sort of motivational interviewing skill sets and manualized 6-week group for these 4 topic areas. So they really go hand in hand, and this might be, again, another area that we want to focus on in not this first year, but maybe in future years as well. So what are the next steps? And then we'd like to definitely open it up to any kind of Q&A that you have. So this is where we're headed right now. And the first thing that you're going to see is that we are developing, with Maricopa County, a website that's going to go live probably, what do you think, Nicole?
I think today. So my goal is to send a follow-up to this webinar that will include that website link for you all.
So that should be the first thing you see next, is that the website will go live. You should be able to link to that, and then all sorts of resources. That's where we'll be posting these resources, so you don't have to go to other areas to look for them, whether it's at our website or other websites. And we'll also be posting this webinar itself on that website as well. So any staff that weren't able to attend today, there'll be these archive webinars that you can send your staff to, or you can send new staff to in the future to look at. We mentioned that these survey, Nicole went over some of the preliminary or some of the aggregate findings today from the surveys, but those reports will be coming out and posted. And so there'll be a general report that you can disseminate and use broadly. We're going to, through November, through early 2018, try to set up meetings with each of the pilot sites. And so those are going to be individualized, where we'll be talking about workflow, but at the same time, what we'll be able to do is give you one of these survey reports that is specifically giving you your findings. So we're not providing that in the aggregate report. We're not breaking that down by site, but you will each individually receive your findings, and that will just inform any kind of workflow, just kind of workflow variables that we need to be cognizant of as we head down the road. We talked about this NRT presentation, so really kind of getting more in depth on cessation pharmacotherapy and probably more specifically nicotine replacement therapy. That's probably what's going to work best in your settings if you use it. And so we don't have an actual date for that, but it will be upcoming in the coming months. We're going to continue to put out a newsletter, so we just want to be able to make sure that Maricopa County is informing you along with us about everything that's new with this pilot project, and making sure you're up to speed. And so we expect that the next newsletter will be coming out in January 2018. You will receive that individually through email, but also, again, all these things will be posted on the website. And then what's really exciting is that we'll be coming out to Maricopa March 19th and 20th to train on the Dimensions Tobacco-Free Advanced Techniques training. So that's that that's that manualized group curricula that we discussed, and the motivational interventions and so forth. And so what we'll be doing is working with you probably through these workflow integration discussions to figure out what staff it really makes sense to send to these trainings. Anything else you want to add to next steps right now, Nicole?
I think that covers most of it.
Okay. And so I'd like to, at this point, just open it up to any questions that all of you have. And so, Sean, are you able to just unmute everyone if they're muted?
Yes. So I can do that, and hopefully we won't have a lot of background noise. If so, I might try and go through and cherry pick the ones that are producing that. So
there's also a Zoom group chat. So if you see that function, if you wanted to type your question, you can do that as well.
So go ahead and chime in if you would like to. And we can also ask Tracy if there's anything you want to add to next steps, or just generally anything you want to add. If anyone's trying to talk and you're having trouble, you might have you might be muted. So someone, Tracy just noted that she doesn't have a microphone. Tracy, so if you wanted to, type in anything you wanted to add, or we can just make sure that if there's any other specifics, we'll just email them out to folks after this webinar as well. So anyone else right now? It's a small group, so you don't have to be shy.
And additionally, if you come up with questions after this is over, the BH Wellness email that I'll send a follow-up on, feel free to submit questions there or to Tracy.
Okay. Well, I'm not hearing any questions right now. I'll give just one more chance before we end. And hearing none, hopefully all of you are as excited as we are about keeping this moving. And as always, you can contact any of us at any time to ask more questions and go from there. Nicole, anything else?
Yeah, just don't hesitate to contact us with questions, and we'll be in touch soon.
Great. Thank you all, and we'll talk to you soon.